I'm now bringing on our first plenary panel discussion for the day. And remember, you can submit questions online as well as in person. Right. So our session is Vital for Recovery. How do we achieve sustainable, equitable recovery of care backlogs across all sectors? Something I know is very much on the minds of everyone here. Here is our panel. Stella Vig, National Clinical Director for Elective Care NHS England. If you want to say hello.
Hello. Good morning, everyone.
Good morning. Samantha Allen, Chief Executive, North East and North Cumbria Integrated Care Board.
Good morning.
Dr. Dominique Allwood, Director of Population Health, Imperial College Healthcare NHS Trust and Chief Medical Officer, UCL Partners.
Good morning, everyone.
And Louise Ansari, Chief Executive of Health Watch England.
Good morning.
Good morning. Welcome to all of you. So remember, you can use Shake It to send in questions. Simply scan the QR code with your phones and tablets. We're live streaming, so you can submit your questions online using the Q&A. And we'll also take questions from the audience, so do start thinking about if you want to ask one in person. But I wanted to ask each of our panelists to speak for about 5 to 7 minutes, and I'll let you know when you've had 5 minutes, just so we have plenty of time for discussion as well. Stella first.
Thank you. I've also just been appointed as National Medical Director for Secondary Care, so this comes from both angles of quality, patient safety, and elective recovery. So the founding principles of the NHS are still as relevant and as vital as ever. And the NHS is ground into the DNA of all of us. And I have to say a huge thank you to all of you, because the NHS has delivered, despite the pressures that we face every single day, industrial action, COVID, flu, we have continued to deliver, and that's because of your leadership. We have virtually eliminated 2-year waits. 65-week waits are now halved. August and September, with no industrial action, we delivered 87,000 more episodes of care than we did in 2019. But as Julian has said, 2019 cannot be our baseline as we carry on. And if we think about the investments in diagnostics and cancer, we've increased our activity and capacity. But we know we've still got pressures coming, and Julian has spoken eloquently to them, and COVID remains a disease process that's sitting with us all the time, and we know it has an impact on the personal health of our patients and our staff, but also on the mental health and well-being of all that we look after. And we now need to stop. We need to reset, reform. We need to listen to our patients and our staff. And our patients are very clear. They're wanting access to timely care in the appropriate place by the right person. And actually, they want secondary care to be the place of last resort. They want surgery to be the intervention that is the last resort through shared decision making. And there is no doubt that the weight that our patients are facing has an impact on their mental health, their economic, their personal lives. And I know that Louise will talk to those in detail. But our staff are asking us to support them. I'm a jobbing vascular and general surgeon down in Croydon, and I see the pressures and the inefficiencies every single day. And we need to release time for care. We need the dignity and value of our staff. But we need to also ensure, as Julian says, that diversity matters. And we need to ensure that the health inequalities that are now becoming more and more obvious are addressed and their needs are met. COVID has taken the cover off what we already knew. But the data now is quite stark, and our NHS is not built for those who really need. And we need to reset and reform. And the quality and patient safety is going to be really important. So it's vital to reset and reform. And our job is to create, as leaders, the right environments for innovation and transformation. And we may say that we don't have time. But actually, we are seeing that innovation and transformation across the country, and that is what's driving our care. But we need to transform together. Julian used the word together. We need to transform together. Wherever there is an interface, whether it's independent sector, primary care, secondary care, community, mental health, it has to be seamless care. And there is so much that we can do together. But what we shouldn't do is each system builds its own. There will be nuances because we are all different, But there is so much that we can do that changes those traditional models of care. And we need to work together. We now have maternity improvement plans, the elective recovery plan, the UEC, long-term workforce plan. There are so many. But actually, the underpinning levers are the same, which are digital, our workforce. And we need to make sure that the oversight is clear and we are setting a single vision and direction. But we also need to be productive together. And if we're productive together, and we really want to make a difference in terms of health inequalities, then we need to make sure that money that's been invested is used well. So we've had investments into maternity, mental health, surgical hubs, the CDCs, digital. Dominique, I know, will talk to prevention and population health, which is where our investment now needs to be targeted as we go forward. But we need to make sure we're measuring the right metrics and the payment processes drive the right behaviours. And I'm not sure we have it just right. So I'm going to stop there and just say, if we are going to manage health inequalities in our population and make sure that the care backlogs reduce in the right way, we need to stop talking about numbers, start talking about people and the patients, and consider what they want for us to transform. So if I may, I'll stop, Samira, and hand back to you.
Fantastic. You did it in exactly 5 minutes to the second, Stella, a star. Could be a broadcaster. Samantha Allen next.
Thanks for that, Stella, as well. I just want to start off by saying, I think, in terms of recovery, and I think particularly elective recovery in our system in the North East, North Cumbria, we wouldn't be where we are without the work of our providers and the way that they've collaborated deeply. There's still more to go at together, but I think the opportunities of the provider collaboratives to be the engine for delivery, and I think particularly around where those services are core services, I still think there's a lot more opportunity there. And I would agree with Julian, it's absolutely the role of integrated care boards and integrated care systems to make sure each part of our system is empowered and enabled to use their strengths. But I just wanted to start with a quote from somebody called Malcolm. So at our recent integrated care board meeting, we put a particular lens on mental health. And Malcolm's quote was really quite simple. He said to us, it's your job, it's our life. It's our life. And I think when we're thinking about recovery from backlogs, a lot of our work in systems, and I think nationally, regionally, locally, is dominated by surgical waiting lists and elective recovery for physical health. Now, it's not to say when we get that right, and in the North East, North Cumbria, we've had a programme called Waiting Well, which has looked at the whole person. We have that real ability to not just address the physical health needs, but absolutely enhance the mental health needs. And as systems, we're really striving for equity across our population. And we know deprivation is probably the single highest risk factor for mental ill health. So those of us working in systems with high deprivation, mental health absolutely incredibly high up the agenda. But we need to be really honest together, I think, to say that if we're going to really tackle this and truly tackle it together, we need a reset. And we need a reset at the national policy level, and we need a reset in terms of what the priorities and the lens of those priorities around our population. And I could equally say the same around when it comes to ethnic health inequalities as well. And again, when we look at mental health, we know the outcomes not just are impacted by deprivation, but also impacted by your ethnicity. This is a story, I think, for those of us who've worked in health and care for a long time, have known over many years. So what's getting in the way of us getting this right? Well, we lack the data, we lack the capacity planning, and we lack the treatment targets. And as we've already talked about, prioritisation. We actually, I don't think, really know how many people are waiting for care, but we think it's about 1.9 million. And that's an 80% increase since 2019 and 155% increase for children and young people. How many of us sat in this auditorium today know somebody personally affected by it? I'm sure many of us would put our hands up and say that. The cost to society is significant. A conservative estimate is about 118 billion. That's 5% of the gross domestic product and a 72% loss of productivity. So if we think about our opportunity working together as providers, as system partners, the real opportunity to benefit the economy is really significant. So quite simply, this warrants more focus. It wants more focus from all of us. If we also look at the thresholds at the moment, when we've got waiting lists, and some of them we're talking about years, we're seeing thresholds for treatment increase. And one of the things I'm observing in that is also focused around a more bed-based model. Systems looking actually, we've got more crisis situations, and we're not putting that lens enough around prevention and population health. If we look at our children and young people, probably one of the single biggest interventions we could all do collectively would be to have an open access on the high street model in a non-stigmatising, non-NHS setting for 12 to 25-year-olds, actually intervening early. And I think also, to Stella's point, we need to be really looking at innovation and models. Because quite simply, even if the funding came and it was available, which we know it's not at the moment, we haven't got the workforce there. We can't magic up the solutions. And if we keep doing what we've always done, we're going to have backlog recovery for not just the next 5 years, the next couple of decades. So we need to be thinking more innovatively together about models. And I think that's where the opportunity comes in systems working together with providers, but also our community and voluntary sector partners.
Oh my God, sorry, just to the second 5 minutes. Just the bar is high today, thank you. Dr. Dominique Allwood.
Thanks, Mira. I may well break that boundary. And I just want to point out as well how fabulous it is to be on stage with an all-women panel. We were just discussing what the name for that is. A fanel, is it a fanel? I'm not sure.
Sounds wrong.
It does sound wrong. Anyway, I'm going to be talking about equity and population health in relation to the backlog and recovery. And I'm going to touch on 4 key areas. And I guess the first one is around prioritisation. Despite being a system that we say is based on prioritising of need, and particularly clinical need, many people wait longer than others based on non-clinical reasons or are more affected by those waits. And that's disproportionate across our populations. And Sam's already alluded to the types of people that have that impact affecting them. One of the ways in which we can start to think about how we tackle that is through a prioritisation lens. And if we think about what we're trying to do there, we're trying to understand what are some of the barriers from a social, economic and structural perspective. And when I sit in clinics with clinicians who say, well, of all the patients that didn't turn up today, I'm somewhat relieved guiltily because I can get something else done or go and see someone else. If we look at that data, if that's twice as likely to be somebody from a Black African population or someone in our most deprived communities, it starts to give a different lens. But looking in our organisations, what can we really do about that? One of the areas is to understand more about those barriers. In my role in my trust, we've been working with an organisation called the Helix Centre that's been doing lots of work to understand and co-produce solutions, and unexpectedly found some things that we wouldn't think that people told us about. But you can imagine the common things that came out around transport, how people were communicated with. University Hospitals in Leicester has done a huge amount of work to tackle DNA appointments, that first appointment that people have that's really important around how they manage that chronic or long-term condition. And things like putting in additional resources to support travel, adjusting communication methods. And I don't think anyone would argue with somebody who speaks your language calling you to talk to you about your appointment or helping you with some transport. But it starts to get potentially more contentious when we start to look at other ways in which we might prioritise patients. Algorithms that start to look at not just the clinical condition in front of people, but actually their wider context. We start to look at the biography as well as the biology of the patient. And also the prospect of potentially ring-fencing resources for people. Now, Barts Health have done that really well. They've created an equity dashboard and looked at patients who are waiting for surgery and saw patients with learning disabilities waiting a lot longer. They ring-fence certain appointments for surgery, creating calm environments, clinicians who had the ability to treat those patients really well, resulting in better outcomes and experience. But I guess it comes to a wider question of where are organisational leaders, clinicians and the public on this when we start to think about equity truly, which is about putting disproportionate effort into certain groups and populations to get the same outcomes. How do we make some of those choices? And I don't think that we've really had that debate strongly enough yet. The second area is what's been touched upon around waiting well, prevention, population health, screening, managing risk factors of people while they're on waiting lists, helping them to manage long-term conditions and prepare them really well for treatment and surgery. Seems like a no-brainer in many ways, but it's not done as well as it could be, and particularly not for some of the population groups that we're talking about. But I guess another choice again about once we start to do these things, we start to uncover things that also require further management, and how do we resource some of that. But we do know the evidence shows that if we do this well, we can get less on-the-day cancellations and often reductions in lengths of stay. So it's an important population health intervention. The third area I want to sort of mention is the unmet need. So many of you in the room will be grappling with those lists and looking at the numbers, looking at patients. But what about the people who aren't on our lists, who haven't yet come in for treatment, for referrals? How do we understand who they are, why they aren't coming, and help them with that? There's lots of things that people are starting to look at, sophisticated population health management tools. I think fundamentally it requires working better across primary and secondary care with the voluntary and community sector to understand that unmet need, why people aren't coming, and to start to look at places where we might expect referrals to be higher. University hospitals in Coventry and Warwick have been doing lots to look at that needs assessment and think about referrals in a different way. And finally, I just want to talk about tech very briefly. And it's been well rehearsed, and I'm sure will come up in other sessions, but thinking about virtual appointments, not only does that potentially help in terms of access, but it also helps with a net zero agenda. And we know there's evidence to show that people who live in rural areas have prohibitive costs for travel, have caring responsibilities, education and work, struggle to often attend in-person appointments. But those who do access virtual appointments sometimes are disadvantaged. Those who are already marginalised and have difficult digital literacy, digital exclusion, those who potentially live in housing that's crowded, how do you find a private space to go and have that consultation? So really contentious issues, and I would say that the prioritisation, the helping people wait well, the tackling unmet need, and thinking about technology are really important ways that we need to think about equity, social determinants and pop health. The final thing I just want to mention is through my organisation, we've been taking an improvement method to all of this. We mapped the pathway of equity from when a patient sort of touches our book, so to speak, all the way through to their discharge, looking at the places that we see inequity through to and how we can help sort of tackle that. We've been thinking about what's in the control and sphere of influence of our organisation using improvement method. So lots to debate, and I'll be looking forward to having some of those questions come up.
Thank you so much, Dominique. Louise Ansari, finally.
Thank you. I agree with everything you said there, Dominic, and great contributions from colleagues as well. So obviously I'm going to be bringing the voice a little bit more sort of directly of patients and communities. First thing to say, of course, is that when people do get through the door, they do tell us that they really appreciate the quality of care and the kindness they receive, and they, you know, people have got such a deep appreciation of the NHS. And I do want to be a dealer in hope, as Julian said, but unfortunately, I also have to tell you a little bit of despair and some things that are happening out there, which I know you know about, but I'm going to outline them a little bit more in terms particularly of inequity as people are waiting. And we were all encouraged not just to think about the planned care backlog, but different kinds of waiting across different services. So I'm going to reflect on the experience actually across 3 areas, and there are a number of hidden waiting lists. So that's people who were waiting to get a referral in the first place for a diagnostic test or for treatment. And our research at Healthwatch has shown that around about 1 in 5 people attend 4 or more GP appointments before getting a referral. And we know a lot of people are having a lot of trouble getting into primary care or GPs at the moment. So there's already a kind of incipient waiting list even before people are getting on the list for getting a scan or a diagnostic test. So then you've got the wait for the scan or the diagnostic test, and then you've got the backlog of getting treatment, and people do also sometimes have multiple cancellations. And we know that people do not attend and have more cancellations and wait longer from particular groups. And in terms of the impact of people, of waiting, people talk to us about their confusion, about feeling forgotten, particularly when communications is really poor or inaccessible. People talk to us about increased levels of pain, symptoms getting worse, and then obviously that leads to pressure on other parts of the system, particularly A&E, or increased number of visits back to their GPs. People talk about sleeplessness, worse mental health, anxiety, and obviously severe harm is coming to some people who keep getting bumped off waiting lists because of cancellations, and we know about the pressures, the industrial action, the other pressures that have impacted on that. The other points, the kind of wider points that Dominic sort of alluded to, were things like the impact on people's finances and their whole life when they're waiting, the impact on their ability to care for others, the impact on their social life, the impact on people's ability to work, and then the greater creation of what we already know is out there, which is this two-tier system whereby richer people are paying to get their scans and diagnostic tests, and then in some case paying to actually get the treatment, and then poorer people suffering more harm. And I'm just going to tell you one individual story of somebody who spoke to us called Barbara, who's a cancer survivor and who uses a wheelchair. In 2022, she was told she needed urgent treatment, had an operation scheduled for a urostomy, and it was cancelled and rescheduled for about a year later in 2023. And she said to us, "I've been living in constant pain for over a year. I haven't received any help from the hospital, though my GP prescribed painkillers. I've been struggling mentally and getting anxious when I have to go to the toilet." So that's for a year. Can you imagine that, being in pain and being anxious every time you wanted to go to the toilet for a year? And unfortunately, we hear thousands of stories like that. So these are people, right? They're not just statistics. We also know that, as colleagues have said, that there are longer waits, more cancellations, and greater impacts in terms of harm, ability to work, and so on, for people in poorer areas, for black and minority ethnic people, for disabled people, for women. And people often say, why is that happening? You know, what are the reasons behind that? And it's often because of their whole life. You know, people are often, their treatment is quite far down on the list because they've got to look after other people, they need to go to work, they're being communicated to not in a clear way, and a whole range of other factors surrounding their life. So what needs to happen is personalisation needs to happen before people get through the door. And there are some really good examples actually in the recent King's Fund report that you might have seen with this idea of prehabilitation, where people are supported whilst they wait. And we've got a number of other more detailed recommendations in terms of supporting people whilst they wait and reducing inequity on the lists.
Ooh, fantastic. Thank you so much. We've got the first question coming in, but one thing I wanted to pick up on. I think it was something, I can't remember if it's Stella or Samantha talked about, under prevention, the possibility of a high street model for 12 to 25-year-olds. I was intrigued by that. Tell me a bit more.
Well, I mean, it may not be on a high street, but could be at a youth centre, it could be somewhere where young people go. So if you look at, again, thinking about young people's mental health, they don't like going to their GP, and actually what we need is more open access models, but also what some people, young people need. They don't always need a specialist mental health worker. They might need to talk to a youth worker. They may need to talk to somebody about some emotional difficulties, a relationship difficulty, or a housing difficulty. So it's much more integrated, multi-agency approach. It was pioneered in Australia, the youth model. There are examples here in England, but it's patchy. We haven't got it everywhere. It's not a universal service, and so these are services that are generally co-produced with young people. It's not something that the NHS kind of designs, but they're very much done in partnership with social care, with education, with housing, and the community and voluntary sector. And if we think about young people's mental health, most of them will have their first instance of mental illness by the age of 14. And our early intervention psychosis really demonstrates that evidence base. So it's a total kind of reconception of the model of care that we've got at the moment, which, you know, for me is based in a sort of a 50s model of care, rather than thinking about actually what do our children and young people need today. But it requires investment, it requires a will, it requires buildings, capital, it requires services to collaborate and come together. This isn't something the NHS can do on its own. It's very much a partnership approach.
So a question that's come in online, we rightly talk a lot about prevention and its obvious benefits, but struggle to actually deliver tangible change. Why does the panel of women think this is? And I also just want to add to it, I'm stunned when you said that we lack data, real data about the scale of the backlog, and that we need a reset. But all your panelists' thoughts about how and why do we tackle the fact that we still seem to lack the ability to prioritise prevention. Do you want to go first, Stella?
So I think prevention is going to be the agenda item for next year. There's now some really, really stark data that looks at treatment of hypertension. It looks at the cardiovascular, respiratory, mental health and cancer. And we know that we can make a difference, but the investment has to be at the front end. And it's difficult because these are very much siloed budgets, and it's how do we work together to ensure that the investment at the front end comes through as savings at the back end of pathways. And really uncomfortable data, I think is how I'm going to put it, to see is that if you are a high earner and from a particular class structure in this country, you will spend a half of your life in good health. If you are not, you will spend 2/3 of your life in ill health. And actually that is often at the top end of your lifespan. And we are all living longer. So the data now is very stark. The investment needed, I think, will come through, but it is absolutely an agenda for next year, because if we don't do the prevention, if we don't invest in prevention, we're going to carry on doing the same, and doing the same is not working.
Dominique?
Yeah, thank you. It's a great question. One of the things we struggle with is this classic wrong pocket, long pocket issue. When we're thinking about prevention, the benefits that we'll see from that won't be potentially in the organisation that might be investing in that, and it won't be in the timescale of a financial year or indeed a tenure of some of the senior leaders. So we struggle to reconcile that often. And I guess the second thing related to that is we have a lot of evidence about the cost effectiveness and impact of interventions that think about prevention. Even things like smoking cessation. In your organisations as healthcare deliverers, the most cost-effective thing you can do is probably help someone stop smoking. Yet we don't prioritise it. It's related to time, it's related to awareness of people, thinking that that's the thing that they should be focusing on that will make a difference. So it is really complex, but we aren't doing some of the basic things well that we know will help us in the long term around length of stay, around financial recovery, etc. And I think it is a really important question. Why are we not doing some of the things we know will make a real difference?
I'm also going to drop in the number of leisure centres that are closing, and obviously that's linked to local government funding budgets, but people can't swim anymore. Stuff that's the most common participation sport. Did you want to go next, Louise, and then Samantha?
Thank you. And I think for NHS bodies, sometimes there's the temptation to say, well, prevention is about the wider determinants of health, and therefore it's about other system partners, it's about local authorities, or it's about public health. But as Dominique said, actually, there are a range of evidence-based interventions that should be and can be done in NHS settings, things like smoking cessation in maternity, things like secondary prevention for diabetes, so people don't go on to get amputations and ulcers and so on. So there are different kinds of prevention, and the NHS still has a significant role to play in secondary prevention and things like preventing long-term conditions getting worse.
Yeah, I mean, there's loads of great prevention work going on, and it's been going on for decades. And But we need to face up to the reality of the situation. And I kind of, you know, the system's perfectly designed to get the results it gets. What are the things that leaders are measured on? Where's the value placed on? You know, it's going to be your 4 hours in A&E, it's going to be your elective recovery backlog. You know, these are all the things that are taking up a huge amount of time of people in this room and our teams. And actually, I think we need to be a bit bolder. And I do think this is the opportunity in systems. We're prioritising, you know, we want to reduce the prevalence of smoking from 13% to 5% in our system over the next 10 years. But we need to set the conditions in the system to enable us to do this. We need budgets over the long term. We need the real value to be placed on population health and prevention. It's not to say the other stuff isn't important, it is, but it's not the only show in town.
Have you got questions in the auditorium? Right, I can see white shirt over there. And just one quick question, Bob, we're getting the microphone to you, which is, one of you talked about the fact that in terms of referrals, people were waiting on average for 4 or more GP appointments. I just wondered, anyone's got any thoughts about the GP element of the backlog issue, which it feels like there's so many pressures on GPs at that entry point. Realistically, how do we deal with that?
So it's interesting. We know that GPs do phenomenal numbers of outpatient appointments. Our practice nurses do 84 million outpatient appointments. We do 120 million outpatient appointments within the NHS in secondary care. But the system is archaic. If you look at the model of outpatients, and if you're a medic, you know what outpatients is. If you work in a hospital, you know what it is. The public don't know what outpatients is. The model is absolutely archaic, and it requires a patient to have permission to seek help through primary care.
What's the alternative to that?
So the alternative to that is actually if we completely break down the outpatient model and completely decide that's just not a term, then actually seamless care would be akin to what is happening in Europe and in the States, where there is open access. There is a conversation that you can't ask the public to have open access to secondary care. But it's really interesting. We rely on the public to go to primary care when they're unwell. And actually, if we can signpost right, and Dominic, you talk to algorithms and technology and self-empowerment, and Louise, you talk to self-empowerment of patients. We need a completely different model of care, but it does need time, investment, estate, all the things that Sam talked about to enable that. But we do need to break down. We need to deliver what the NHS needs to deliver, but the mechanism of delivery now has to be very different.
Okay.
And Sam is right, the systems are the way to make that change.
Let me take that question over there. Go for it.
Jack Tarsing, Chair of Coventry Warwick Partnership Trust. First of all, can I just add my applause to such a diverse panel, and what a great start to an NHS national conference that's focused on health inequalities, that's focused on equality and diversity.
But we have very little time.
But yeah,
so
the question
go for
is, new Secretary of State, honeymoon period, what is the one thing you would ask the new Secretary of State to do for you in the next 12 months?
Thank you. Or do you want to go first? And then
Well, Jad, it's lovely to see you. My ask would be, let's not change direction. We are achieving. This is not time to double back. We need to carry on with the visions that have been set.
Anyone else?
I've to get an end to industrial action. Absolutely, it's not done, is it? So we need to see an end to that. And I think listen deeply, but you've got a great set of leaders working in health and care, set the conditions and enable them to do what they know is best.
Dominique.
Yeah, I think I'd echo what Sam says, setting the conditions. Leadership is key here, isn't it? And destabilising that at this point feels really precarious. So, yeah, I would echo what Sam said.
And Louise.
Go and listen to patients and listen to communities and listen to the public. Don't just focus on the statistics. Understand the experience.
Thank you. We could take one more question if we've got one. Yes, just behind where the gentleman was in the red top. Thank you.
Hello, Janine LaRosa, Chief People Officer at BHRUT. It's been really wonderful to hear you visioning for the future and breaking down silos and so on. But we are here as employers within the NHS and across health and social care. The NHS is one of the largest employers in the world with 1.3 million or thereabouts staff. What might we be able to do to fast track some of that health inequalities piece if we were to focus on our staff, who are largely made up of the populations that are most likely to be socioeconomically deprived and living in challenging circumstances?
Thank you. That's such an interesting question. Yeah, do you want to go first, Samantha?
Yeah, just one quick one. So, yeah, massive employer, 5th largest in the world, 78% of the workforce are female, focus on women's health. And we know a large percentage of that workforce are in the lower banded levels. You know, if you can do one thing and do it right, focus on the health of your workforce and enable them to access that quicker. They're doing some fantastic work in Lincolnshire, Project Mimosa, where they've given all of their staff access to a consultant-led menopause clinic, and actually it's helping with retention and work satisfaction as well. That's within your gift. Please do it.
Okay. Everyone else, do you want to go next?
Yeah, as staff as your first population, health in, health out, I think is absolutely crucial. I guess the equity lens equally applies. Not all interventions will be the same across population groups. If you think about things like active travel, it's great being able to provide the Ride to Work scheme, but when you look at the data, it's Bromptons and triathlon bikes being bought by people. That's not going to empower the diverse range of staff that we have to get active. So I think bringing the equity lens into that as well is really important.
Louise?
I think, you know, supporting the mental health as well of staff is incredibly important, because people understand the burnout issue and the morale issue. So, you know, whatever can be done in terms of occupational health effectively for staff, that will help patients as well.
A final word to you, Stella.
And I'm going to hand back to you, because we are accrediting surgical hubs, and I did a fantastic visit to Barking-Havering, to your surgical hub. And what was palpable in the room was that the organisation had listened to its staff, had looked at the nuance that affects Barking-Havering, Redbridge, and you have enabled your staff to deliver something that is absolutely phenomenal. And if we can bottle that up and get that in across the country, it will make a difference. So I'm going to ask you to let us know what you think.
Thank you. Terrific panel. Thank you for your questions. Thank you.